In this vaginal bleeding lecture, we're going to cover the anatomy and then the diagnosis of exclusion, abnormal uterine bleeding. When you get to this point, that is the non-pregnant reproductive age female, I want to give you an advanced organizer for remembering the different causes. And that's not something I made up. It's palm coin with an E thrown in. Palm is the structural causes, that is the anatomy, and coin is the non-structural. You want to give consideration to polyps, adenomyosis, leiomyomas, that's fibroids, and malignancy. Now, malignancy is going to mean both endometrial and cervical cancers. We're not going to talk about that here. That was talked in the cancer lectures. The non-structural causes are going to be sort of more vague and ambiguous. That is things like coagulopathy, someone who has platelet disorders or an elevated INR, ovarian dysfunction, which is where we're going to go to explain dysfunctional uterine bleeding, problems of the endometrium, iatrogenic, which effectively means IUDs, see the I, and then N, not yet classified, which basically means everything else but makes a mnemonic work. Structural, non-structural. So we are going to talk first about anatomy, the structural diseases, but we're going to leave out malignancy. So when you're considering anatomic causes, there's three things you really want to give a lot of thought to. That is fibroids, adenomyosis, and polyps. This is a normal-looking uterus, fallopian tube in the ovaries. Fibroids are benign growths in the myometrium. It depends where they are, whether they're serosal or submucosal. But effectively what happens is the nice smooth uterus is replaced by this nodularity. So what you're going to see is an asymmetric nodular uterus compared to adenomyosis, which is proliferation of glandular tissue into the myometrium, which effectively makes it very thick and the lumen very small. This is going to be symmetric, smooth, and boggy. Versus a polyp, which is a normal feeling uterus that happens to have a little dangly in it, which you only identify once you actually look into the uterus. The only one of these we're really going to talk about is fibroids. I just want you to see what it might look like and then use that to correlate with the physical exam finding in case a question gets thrown at you like that. But because fibroids are so common, that's likely where the questions are going to go. Fibroids, leiomyoma, are benign growths of the myometrium. That is, leiomyomas do not progress to leiomyosarcomas. If you have a cancer of the uterus, it did not come from a fibroid. And they are estrogen responsive. They proliferate under estrogen, which means they get worse during cycles. After menopause, they tend to regress. And fibroids can present in any way. They may present asymptomatic, just a nodularity that you feel while you're performing a physical exam. They may present with anemia or bleeding, which is why we're talking about them here, because they're highly vascular. They could be painful, and this is a problem that a lot of people have with fibroids. And because it takes up the lumen of the uterus in an asymmetric fashion, it can lead to infertility. And if they're bad enough, particularly if they are subserosal, if they're big enough, they can actually cause visceral obstruction. Obstruction of the ureters, bladder, kidneys, and bowel. You're going to feel them, right? If they're big enough to cause a problem, chances are you'll be able to feel them. But the diagnostic step, the first one and the only one you need, is a transvaginal ultrasound. The best radiographic test is going to be the MRI, and the MRI is able to separate out a leiomyoma from a leiomyosarcoma. But generally, you do not get the MRI because it is expensive and does not yield any benefit. The only time you'll need that MRI is when the ultrasound is suggestive of malignancy rather than the fibroid. The absolute best test, of course, is a biopsy. But you'll not need to do that, one, because they're highly vascular and they'll bleed, and two, because you make the diagnosis clinically and just with the transvaginal ultrasound. The treatment is where a lot of different issues come up. You can treat them with meds, and you can treat them with surgery. The first line therapy is OCPs, and anytime we say OCP in this lecture, we mean also IUDs. The problem with fibroids, though, is that implanting an IUD and then not having it fall out is a little hard, so OCP is generally preferred. As backup for pain, but generally not useful as monotherapy, is NSAIDs. If you have to pick a medical therapy for fibroids in general, pick OCPs. For surgery, you have to decide, does she want kids? Because it will be very different if she does not want kids. If she wants kids, she gets a myomectomy. She just scoops out the fibroid. This is a lot harder to do. There's probably going to be recurrence and the symptom relief isn't as good, but it maintains her fertility. If she doesn't want kids, you can do a total abdominal hysterectomy and you remove the source of pain and bleeding. Satisfaction rates are very high, but she just has to be done with wanting kids. If you're going to do a surgery and the fibroids are too big, you can do continuous GnRH therapy with leuprolide, which shuts off the axis, essentially induces menopause, turns off the estrogen production, shrinks the fibroids, then you cut them out. So you can see that this could be a very easy test question. First line therapy, OCPs. If pain's the issue, NSAIDs. If you're going to do surgery but you need to shrink the fibroid, leuprolide. You're going to cut it out and she doesn't want kids, hysterectomy. You're going to cut it out and she does want kids, myomectomy. Adenomyosis and polyps are essentially managed very similarly, except they don't have the medications. They're just going to be more surgical. And they present the same way and are worked up the same way. So we're not going to talk about them in detail. I do want to talk about abnormal uterine bleeding. And when it comes to this, the patient and the diagnosis essentially are the same. It is a diagnosis of exclusion. That is, you've gone through the process of working up coagulopathies, you've ruled out other diseases like thyroid, prolactin, you've done imaging like an ultrasound or an MRI, but you only do that if you suspect a disease. You don't just screen people with an MRI. You've gone through pregnancy, anatomy, and are left with dysfunctional uterine bleeding, also called abnormal uterine bleeding. The pathology here is thought to be anovulation, and that is to say, during the first half of the cycle, it is estrogen predominant, which increases proliferation. At day 14, there's ovulation, and progesterone takes over. This reduces proliferation. In an anovulatory person, there is no ovulation, so there's no switch to progesterone, so estrogen predominates. Estrogen builds the endothelium, and at a time that she can't control, the endothelium exceeds its vascular supply and dies. So she has bleeding that occurs irregularly. It may be heavy, it may be light. It's this combination of things that we don't really understand that produces it. Abnormal uterine bleeding is normal near menarche and menses, as the system's getting going and as it's turning off. It's only abnormal, truly abnormal, in the reproductive age after she started having normal menses. And when you diagnose abnormal uterine bleeding, you're effectively saying, look, I don't have anything to tell you, I don't have anything to treat, but we're still going to make you feel better. And what you're going to get in the way of the test is the option to decrease stress and anxiety, going after hypothalamic causes. If you're at the point of abnormal uterine bleeding, that's probably not going to work. The same thing is true of weight gain. Unless the person is vigorously exercising, marathon runner, or has body dysmorphic disorder and has having abnormal periods, that's probably not going to be the answer either. Most of the time, stress, anxiety, and weight loss are going to cause amenorrhea, not excess bleeding. So if you have excess bleeding, you need to turn to medical therapy or surgical therapy to stop the bleeding. As with fibroids, the first line is OCPs, and OCPs equal IUDs. Take over the cycle, don't let her body do what it naturally does, stop the bleeding. You can also use NSAIDs. And NSAIDs, unlike in fibroids, which are mainly for pain, NSAIDs can actually reduce bleeding. And this makes people recoil, right? Because NSAIDs are antiplatelets, should make her bleed more. It turns out that NSAIDs have a predominant effect in the uterus on prostaglandins and not so much effect on the platelets. So NSAIDs can actually hold off the bleeding. So the idea is you give her some NSAIDs, make the bleeding stop, put her on some oral contraceptives and see how she does. If she no longer wants the medications or she continues to bleed, surgical intervention will be required. And you can do that either with an ablation or you can do it with a hysterectomy. Both cases are going to remove her ability to have kids, but the bleeding will stop. One particular cause of anovulation is polycystic ovarian syndrome. And I want to spend a little bit of time on this because this is our only time where we're going to spend time in detail. The pathology of polycystic ovarian syndrome is anovulation. Anovulation is going to cause predominantly an estrogen-dominant system. But there's also atretic follicles, thousands of follicles that produce testosterone. And that is what separates PCOS from every other form of anovulatory uterine bleeding. PCOS predominates in testosterone, and testosterone is going to make her more like him. That is, she becomes fat and hairy. But more importantly, PCOS is an endocrinology disease. So you're going to look for things like metabolic syndrome, not just obesity, but you're also going to see hypertension, dyslipidemia, diabetes. And these patients will present with infertility because of anovulation and also menometrorrhagia. They have no control over their periods and they're highly variable. And as you work this person up, the way you make the diagnosis is by meeting a certain set of criteria. The diagnosis is made by a history of anovulation, and this is obtained just by talking to the person and getting their symptoms. And one of two things. You either need biochemical evidence of hyperandrogenism, or you need imaging evidence of lots of follicles. That is, you get an ultrasound that shows follicles, or you have biochemical evidence of elevated androgens. So an elevated DHEAS, an elevated testosterone, or, and this is what you should pick on the test, an LH to FSH ratio greater than 3:1. This ratio is what they love to test on. LH to FSH ratio greater than 3:1 is the biochemical evidence of polycystic ovarian syndrome. You don't need the ultrasound to prove it. The point is you don't need the ultrasound, but the ultrasound can be used to make the diagnosis. And if you have the diagnosis, the history of anovulation, and either biochemical evidence of excess androgens or imaging of follicles, atretic follicles, on the ultrasound, then you should treat her. Weight loss and exercise can actually have some pretty powerful results, but it is never used as monotherapy. The goal here is to push her into ovulation. Metformin is the mainstay of this disease, not just because they develop metabolic syndrome and might have some insulin sensitivity, but because the metformin actually helps with pushing them into ovulation. Don't worry about why, just know that patients with PCOS should be on metformin. If she does not require pregnancy, OCPs are highly effective. And of course, as we said, OCPs equals IUDs. Take control of her cycle. If she does want to get pregnant, we need a big push into ovulation in order to get those eggs to be released to be fertilized, and that is with clomiphene. And lastly, she's hirsute. She probably does not want to be. Cosmetically speaking, you can reduce the hirsutism with anti-androgens like spironolactone. Okay, in this lesson we talked about an advanced organizer for approaching bleeding in a reproductive age person. We talked about anatomy, focusing primarily on fibroids, recognizing that what you need to do is OCPs, NSAIDs as an adjunct, leuprolide only if you want to shrink the tumor, myomectomy if she wants kids, hysterectomy if she doesn't. We talked about abnormal uterine bleeding, which is but you're bleeding. So try NSAIDs first, then OCPs. If that doesn't work, some sort of surgical procedure where you burn away or remove the endometrium so she doesn't bleed anymore. And then we talked about PCOS, which is an endocrine diagnosis based on anovulation, elevated androgens, or atretic follicles on ultrasound. That is vaginal bleeding, reproductive age.